Hello everyone. My name is Abuzar Asif and I'm a second year internal medicine resident at OSF St. Francis Medical Center at University of Illinois College of Medicine in Peoria. I along with my co-authors would like to present this interesting case of fulminant pancreatitis due to disseminated histoplasmosis. A 41-year-old female presented to our hospital with complaints of epigastric pain which was radiating to her back. She had a past history of hypertriglyceridemia and interstitial cystitis for which she was on chronic intermittent steroid therapy. She had been hospitalized multiple times in the past for acute pancreatitis due to hypertriglyceridemia, with her triglyceride levels in the range of 5,000 at those times. On physical exam, she had a diffusely tender abdomen and a negative Murphy sign. Her tests showed an elevated white count and elevated lipase levels. CT abdomen showed findings of pancreatitis and peripancreatic fluid collections. So formal diagnosis of acute pancreatitis was made and she was treated with intravenous fluids and analgesics. However, her hospital course was long and it was very complicated. She did develop renal failure and was initiated on hemodialysis eventually. She also developed necrotizing pancreatitis, which then gradually progressed to form a necrotizing peripancreatic abscess and a pancreaticoduodenal fistula. In figure 2, a CT scan of the abdomen clearly demarcates the peripancreatic abscess. Figure 3 shows an upper endoscopy image clearly showing the fistula and a percutaneous drain visualized through the fistula. For these reasons, the patient underwent extensive debridement and necrosectomy, but eventually passed away from suspected septic shock despite aggressive measures. The family requested a post-mortem autopsy to be performed, and the results showed that she had severe necrotizing pancreatitis and necrotizing granulomatous inflammation with histoplasma capsulatum involving the lungs, the spleen, liver, and mediastinal lymph nodes. Figure 4 shows the histology slide of her pancreas on post-mortem autopsy, clearly showing the fatty necrosis of the pancreas on H&E staining. Figure 5 shows another slide of necrotizing granuloma in the lung found on H&E staining. When a Grow-Card methenamine silver stain was applied to the lung granuloma, it clearly visualized the budding yeast of Histoplasma capsulatum. Based on these findings, a formal diagnosis of disseminated histoplasmosis was made and the patient's family was informed about it. To further discuss this interesting and very rare case, I would like to mention that most common causes of acute pancreatitis like alcohol, gallstones, and hypertriglyceridemia were all ruled out in our patient at admission itself. She did have some known risk factors for her causing a histoplasma infection like being on chronic steroid use therapy for interstitial cystitis, which could have contributed to her immunosuppression and increased her risk of acquiring the histoplasmosis. She was also from the Midwest region of the United States, which is endemic to the histoplasmosis. Given all these thoughts, in hindsight, if we would have tested her for histoplasmosis at an earlier stage, it could have possibly prevented a poor outcome. On our literature review, we did find 5 other reported cases of histoplasmosis involving the pancreas. 2 of these 5 cases were of isolated involvement of the pancreas. We would like everyone to take home at least 3 points from this entire presentation. Histoplasma capsulatum is a rare etiology of acute pancreatitis, and if missed at presentation, can lead to life-threatening complications as seen in our patient. Disseminated histoplasmosis usually involves the immunocompromised individuals, but cases of immunocompetent patients have also been reported and therefore should not be overlooked. There's also an increasing need to utilize PCR assays and next-generation microbial cell-free DNA sequencing, like Caris testing, that may help detect Histoplasma capsulatum earlier than traditional time-consuming techniques like fungal culture. I would like to thank everyone for listening to our presentation patiently and wish them a good day. Thank you.